Start, sir.
Can we start, sir?
Yes, Tejasvi.
Yes, sir. Good morning. Today we will be discussing regarding the second part of the oncological emergencies. Last week we have discussed regarding the metabolic complications, neurological, psychological, cancer pain, and renal neurological complications. So today we will be discussing regarding the immunohematological emergencies, respiratory and GA complications, and the cardiovascular complications. We will be, because it's since a lot, we will be discussing the most important parts of these. So coming to the immunohematological part, firstly, like these are the acute complications which evolve come something related to the immune system and blood. So the hematological complications mainly are drug-induced hypersensitivity reactions, infusion-related reactions, transfusion reactions, disseminated intravascular coagulation, and bleeding disorders. The mainly the mechanism for hematological emergencies are might be because of disruption of blood cell products or destruction of the components of blood or coagulopathies, or it might be because of rapid proliferation of the malignant cells leading to marrow failure. And regarding the immunoemergencies generally we see more commonly with CAR T cells or T cell therapies, or we also see with other therapies like immunotherapies and targeted therapies. So the immunoemergencies mechanisms, it's because overactive immune response will be there, which leads to the cytokine release syndrome and immune checkpoint inhibitors causing autoimmune reactions and graft versus host disease in post-transplant patients. All these are mechanisms for immune emergencies. And because of the interaction between immune and hematological system also, this is one of the common pathophysiology seen with immunohematological emergencies. So drug-induced hypersensitivity, as we all know already, so it will be like fever, skin reactions, and lymphadenopathy, and internal organ involvement. These are the common features which are seen, and they develop 8 weeks after starting the drug. And the most common drugs are other things like anticonvulsants, allopurinol. In systemic therapy, we have systemic chemotherapy. We have some common drugs like sulforamide. Involved drugs and some anti-neoplastic agents are common with the drug-induced hypersensitivity syndrome. And infusion related reactions, they occur within 1 hour of infusion, and it can be immediate sometimes, delayed sometimes, and severe anaphylactic reactions. Common triggers in chemotherapy are platinum compounds and taxanes and monoclonal antibodies. These are the common things where we have infusion related reactions. So to prevent that, or to decrease the incidence of these, what we do is whenever we give any chemotherapy, whenever we are giving platinum, taxanes, or monoclonal antibodies, we give an antihistamine before giving these kind of chemotherapies. So as told, generally for the treatment we give supportive care or antihistamines or steroids before the as pre-medication before the chemotherapies, and epinephrine if it's very severe. And transfusion reactions are acute intravascular hemolysis, any allergic reactions, febrile non-hemolytic reactions, and transfusion-related lung injuries and volume overload and bacterial contamination. These are all the transfusion reactions which we see. And we generally give them supportive care treatment based on reaction type. And the treatment approach is similar, that is supportive care with antihistamines or steroid, and epinephrine is if it's very severe. So coming to one of the important aspect of this immune and hematological complications of cancer, that is disseminated intravascular coagulation. So the mechanism is the tumor, whenever there is a tumor, it causes endothelial disruption, leading to platelet aggregation and widespread microvascular thrombosis and vascular occlusion occurs. And this tumor also, it elaborates the tissue factors, procoagulant factors, and leads to release of interleukin-6, which again further adds on to the microvascular thrombosis, and because of which all the clotting factors are consumed and there will be bleeding and plasmin activation leading to fibrinolysis, which further leads to bleeding. So this is the mechanism how a tumor causes this DIC. So common cancers where we see DIC, most common is acute promyelocytic leukemia. So the most common cancer associated with DIC, and but even then the incidence of APML is very rare. DIC can occur before or during the chemotherapy also for APML. And other things are the mucin producing adenocarcinomas, and some mucin producing adenocarcinomas, most common is pancreas. So some other solid tumors like lung, breast, pancreas, ovary, and kidney and stomach, all these cancers may cause DIC in the severe stage. And signs and symptoms, common clinical manifestation which we see are fever, hypotension, and acute organ dysfunction, petechiae or purpuras, and hemorrhagic complication. Hemorrhagic symptoms also we see more commonly, and thrombotic symptoms. As we know, DIC has both hemorrhagic as well as thrombotic complications. And in the lab, we do blood coagulation profile, fibrin degradation production, platelet count and function will be checked. And for DIC, we need to rule out the other causes like TTP, HUS, and severe sepsis. And the key main differentiators which we see in the lab are cystocytes in the blood smear, and elevation of D dimer, and clinical correlation with sepsis or other trauma. So next, coming to the scoring systems. So DIC is scored using an international scoring system, and it's a Japanese and Korean scoring systems are also present. But what we follow usually is the international scoring system of for thrombosis and hemostasis. DIC scoring system. It is based on several clinical laboratory findings, but few important things in that are the level of platelets, the fibrin markers, the prothrombin time, and fibrinogen. So these all are the main part of the scoring system of the international DIC score. And we also have the Korean and the Japanese scoring system. In the Japanese scoring system, generally they use the systemic inflammatory response syndrome score, that is SIRS, and organ failure as addition to the other brief scoring systems of the international one. And general management principles, what we see are hemodynamic stabilization, monitoring and supportive care, and addressing underlying cause of the DIC. So these are the other management principles which we see. So firstly, whenever there is a DIC, we like a regular DIC, even for the cancer also, we need to identify and treat the infection with antibiotics, and any surgical intervention for trauma or malignancy related DIC, and obstetric complications or any other things during that time are also to be managed. But mainly for cancer, we just see like what is the main cause, and then we need to treat the cause of the DIC along with giving a supportive treatment for them. And stabilizing the hemodynamics, that is a important that plays an important role in supportive care. And anticoagulation therapies are heparin or use of direct oral anticoagulants, and we have to balance both hemorrhage and thrombotic risk in a DIC. So commonly what we do is going for direct oral anticoagulants. So blood product which we give is based on the product which is required, like either platelets or fresh frozen plasma or cryoprecipitates with fibrinogen can be given. And the other complication which we commonly see with CAR T cell therapy and immunotherapies is cytokine release syndrome. So how does the cytokine release syndrome occur? It occurs in the role of a CAR T cell therapy whenever it is given. Whenever a CAR T cell therapy is given, then there might be activation of the T cells and release of cytokines. And this impact of cytokines like interleukin 6 and interferon gamma, they cause this cytokine release syndrome in the blood. And presentation is they present with mild flu-like symptoms to severe multi-organ dysfunction. The range varies with having a small having a signs like fever, tachycardia and all. To it may be also through ARDS and organ dysfunction syndrome also. And there are various diagnostic criteria for CRS, and management is by giving anti-interleukin 6 like tocilizumab and corticosteroids. Corticosteroids are the first step. And later on, if the patient is refractory for corticosteroids, oxygen therapy, and vasopressin, then we go with tocilizumab. So coming to the other important complication which we see regularly is the febrile neutropenia. Generally, febrile neutropenia plays a very important part in oncological emergencies, as told, because this is the most common complication which we see regularly with the cancer and chemotherapy patients. So febrile neutropenia, it is defined as a fever with single temperature more than 38.3 degrees or more than 38, which is sustained for more than over 1 hour, And neutropenia ANC of less than 500 or expected to decrease less than 500 within 48 hours. And the incidence is about 10 to 50% in solid tumors, where then more than 80% febrile neutropenia is seen in hematological malignancies. So both fever as well as this neutropenia should be combinedly present to call it as febrile neutropenia. And mainly the pathogens which are said to be common in febrile neutropenia are gram-positive bacteria and cons and Streptococcus viridans. And sites are mainly blood bacterium in 20% of cases. We see in intestine, lung, and skin are the main sites of infection. Coming to the symptoms, fever and temperature thresholds will be there, like criteria for fever and temperature ranging, and low grade or high grade fevers might be there. And risk assessment, how do we do the risk assessment for febrile neutropenia is through MASCC scoring index. And here we generally follow burden of illness, whether it's mild, moderate, or severe. And is there any hypotension? Is there any COPD? And solid tumors or lymphomas? And is there any previous fungal infection? Is there any dehydration? Or what is is the patient an inpatient and outpatient? Or age of the patient is less than 60 years, and score will be more than 21, and low risk score if it's less than 21. If it's more than 21 or less than 21. And high risk category, MASCC score is less than 21, and there is profound neutropenia, that is ANC is less than 100, which is expected for more than 7 days. And significantly, we have other comorbidities like hemodynamically unstable or oral GA mucositis, neurological changes, catheter-related infections, or any organ dysfunction, or there is new pulmonary infiltrates or newer hypoxemia which is being developed. These are all considered as high risk category according to the MASCC. So based on these categories, we give varied treatment to the febrile neutropenia patients. And this is the CTCAE grading. CTCAE is the common terminology criteria for adverse effects, which is followed for most of the adverse effects in oncology. So whatever is the adverse effect, we grade them according to the CTCAE. So here in febrile neutropenia, we have like before coming to febrile neutropenia, we call it as neutropenia. We have the ANC grading. So whenever the ANC is up to 1500 is grade 1, 1000 to 1500 is grade 2, 500 to 1000 is grade 3, and less than 500 with a persistent temperature is called as grade 4 or febrile neutropenia. So we also have grades for other like anemia and thrombocytopenia also, CTCAE. And based on this, we grade as febrile neutropenia. And coming to the initial evaluation, how do we evaluate? So patient history and physical examination, lab and diagnostic workup is very important in febrile neutropenia. And early risk stratification we generally do based on all the scores which we do in a normal critical care unit. And along with that, we also do some scoring with the MASCC for febrile neutropenia. And we give some empirical antibiotic therapy. And based empirical antibiotic therapy is a broad spectrum antibiotic which we give initially, and antibiotic choice is based on local resistance pattern and antibiograms. And after that, we also give some route of administration through within the first hour of diagnosis. We need to give the antibiotics and choose appropriate route of administration like IV for severe infections, and then later on we can switch to the oral antibiotics. And we need to monitor the patient both of the clinical signs and the laboratory tests, and daily we need to repeat and check the ANC. If the ANC is improving and the fever is subsiding, then we can change it to oral antibiotics. And coming to supportive care, hydration, electrolyte management, fever and analgesia control, and nutritional support is very important to manage febrile neutropenia. So what are the prevention strategies for febrile neutropenia? So in this, prophylactic antibiotics whenever it is indicated, for generally for most of the hematological malignancies, they will be on prophylaxis. Bacterial, fungal, as well as viral prophylaxis is being given for most of the hematological malignancies. And growth factor support in high risk patients. So in a few of the chemotherapies, we generally give a growth factor support, because wherever it is indicated, like wherever there is a chance of febrile neutropenia more, like example, we can take it as a few taxanes like docetaxel, where within 24 hours after giving the chemotherapy, we generally administer a growth factor. This is just to support the neutropenic phase. It has an nadir of around day 11 to 12 post chemotherapy. There is a neutropenia phase, complete neutropenia. So the patient may land up in febrile neutropenia and have multiple infections of the GI or any other organ. So to prevent that, we give them growth factor support, that is a pegrafil, or we give them GCSF, granulocyte monocyte colony stimulating factor, within 24 hours after giving the chemotherapy. So this is in high risk patients according to the MASCC score. And we also have to check on regular monitoring during chemotherapy, good hygiene practices, and patient education and early recognition of symptoms. So all these come under the prevention strategies to prevent febrile neutropenia. And next, coming to the cardiovascular system emergencies. So, the major cardiovascular complications which we commonly see are malignant pericardial effusion, cardiac tamponade, and chemotherapy-related heart failures, arterial hypertension, MI, arrhythmias, QT prolongations, radiation-induced cardiotoxicity, VT, that is venous thromboembolism, superior vena cava obstruction, and complications of central venous diseases, septic shock, and extravasation. In these, majorly, we will just concentrate on few important points regarding each, and the important cardiac complications which we need to concentrate are VTE and SVCO mainly. So coming to the pericardial effusion and cardiac tamponade. So pericardial effusion, around 10% of the cancer patients are at autopsy only, they are identified to have a pericardial effusion or cardiac tamponade. So most common cancers which lead to these are 30% of lung cancer patients, in breast cancer, melanoma, and leukemia, lymphoma patients. And clinical presentation, they present with dyspnea, chest pain, cough, palpitations, or orthopnea, and they have signs of decreased heart sounds, neck vein distension, and peripheral edema. Mostly, we see these kind of pericardial effusion or cardiac tamponade in the stage 4 diseases, or else any obstruction, even in the earlier stages. And coming to chemotherapy related heart failures, there are two types of chemotherapy related heart failure. One is type 1 and type 2. Type 1 is because of cytotoxic chemotherapy agents. Type 2 is because of the monoclonal antibodies or biological agents. So this type 1, which is whichever cytotoxic agents they cause irreversible damage to the heart muscle, and which is dose related, and there are structural changes which occur post giving cytotoxic agents more than the cumulative dose which is indicated. Example are the anthracyclines which we give in a normal chemotherapies like for breast cancer. And in type 2, we have with biological agents, these are reversible and they are not dose related, and there are no structural changes. Example is trastuzumab monoclonal antibody, again, which we give for the breast cancer and other cancers also nowadays regularly. And this trastuzumab, it has a reversible indication. That's why whenever we give a trastuzumab chemotherapy to the trastuzumab monoclonal antibody therapy to the patient, we generally do a 2D echo. Perform a 2D echo every 3 cycles once, just to be careful with the heart failure purpose. And if there is any alteration in the 2D echo, we immediately stop the trastuzumab for fewer cycles, and there will be a reversibility of the heart changes which occur. And anthracycline cardiotoxicity risk factors mainly are the cumulative dose, as we have discussed, extreme age, female gender, cardiovascular diseases, hypertension, or any combination therapy which we are giving, and prior radiation given to the given. So these are all are the main risk factors for cardiotoxicity due to anthracyclines. Here we need to regularly monitor the left ventricular ejection fraction, biomarkers like TROP-I and BNP, and early detection is very, very important with anthracycline cardiotoxicity, because it is an irreversible cardiotoxicity. And once the patient's cardiac function has been altered, then it is very irreversible with anthracyclines. Whereas targeted therapy cardiotoxicity agents are trastuzumab, lapatinib, sunitinib, bevacizumab, and imatinib. All these are monoclonal antibodies. And the clinical features are asymptomatic left ventricular ejection fraction decrease. It can be reversible. They have some symptomatic heart failure, and usually it is reversible and it requires more regular monitoring. That's why every 3 cycles once we just go for a 2D echo being done. And arterial hypertension common with anti-angiogenic drugs. Anti-angiogenics are the VEGF inhibitors. These VEGF inhibitors are also monoclonal antibodies like bevacizumab, sorafenib, sunitinib, and pazopanib. So these are common drugs where the most common complication is arterial hypertension. So whenever we are giving these drugs, we generally do a regular blood pressure monitoring, AC inhibitors, calcium channel blockers, or any dose modification if it's indicated. And myocardial ischemia causing agents mainly are the 5-fluorouracil. So this 5-FU is a medication. It's the most common chemotherapy which we give in most of the cancers. Like we generally give it in head and neck cancers, stomach cancer, and we also give in most of the other cancers like colon and rectal cancers also. So this 5-FU, whenever we are giving this 5-FU, there may be any myocardial changes which may occur, like a spasm or any kind of Prince metal angina is also expected with this 5-FU. So whenever we give a 5-FU, before giving the chemotherapy, we generally assess with the patient with an ECG and 2D echo. And also whenever the patient during the chemotherapy with 5-FU, if the patient complains of any chest pain, we immediately need to stop the chemotherapy immediately, do a 2D echo, and then assess his status of the heart. So this 5-FU is very, very important in a myocardial ischemia kind of complication. And the other things are capecitabine, paclitaxel, docetaxel, and bevacizumab. They also have some minimal effects on myocardial ischemia causing type of agent. But 5-FU is most important out of all, and we need to immediately manage by stopping the offending drug, that is the drug whatever is causing, and anti-anginal therapy is to be given immediately, cardiac support. And whenever we are doing a re-challenge post giving this kind of chemotherapy, we have to assess the risk and benefit before doing the re-challenge. If possible, we can try to use any alternative for this kind of chemotherapy, whenever there is a complication. Then QT prolongation, the main risk factors are any electrolyte disturbances or any combined medications or any underlying cardiac diseases there. Then there are QT prolongation is more. And for QT prolongation, we need to monitor with regular ECGs. Generally, the drugs like pazopanib, or as we have already seen, some of the tyrosine kinase inhibitors, the most common complication with them is the QT prolongation. So for this, we monitor regular ECGs, we monitor electrolytes, QTC is calculated, and risk assessment is being done. And we need to correct the underlying factors. We can modify the drug in case if there is QT prolongation, we need to stop the drug for few months and then restart once the QTC is settled. And close monitoring is required in QT prolongation causing agents. And radiation-induced cardiotoxicity, if the radiation dose is more than 30 gray and volume of heart is exposed, like during breast cancer, the heart is contoured to get the minimal effects during breast cancer treatment with radiation. And it also depends on the delivery technique by the radiation oncologist, age, and combined therapy. And other cardiovascular risk factors are also very, very important before calculating the cardiac risk in radiation. So the main effects with cardiac risk with effects are pericardial diseases, coronary artery disease, vascular disease, and some conduction abnormalities might be there with radiation induced cardiotoxicity. And coming to the other vascular complications, that is VTE. So risk factors for VTE in patient with cancer are the type of the tumor. So very high risk is seen with pancreatic, gastrointestinal, and brain tumors. Pancreatic and gastrointestinal are the most important things which we have to remember in VTE. Most of the pancreatic cancer during presentation itself, they generally present with VTE. And high risk are the lung, gynec, bladder, testicular, renal, and lymphomas. Lymphomas are very important tumors where we anywhere in the anywhere they may cause this VT symptom. So this lymphoma is one of the important thing which we have to have a watch on. Then oncological therapy related risks like platinum based chemotherapies like elaspagines, mitomycin, immunomodulatory agents, and hormonal therapies, all these have a risk of causing VTE. And some treatments like erythropoietin stimulating agents or any transfusions or radiation therapy, use of GCSF, and surgery. These are all the treatment related risks. Patient-specific risk factors are old age, BMI is more than 35, males, with decreased performance status, liver disease, major fracture or severe soft tissue injury, and any active malignant neoplasm present. All these are the patient-specific risk factors for VTE. So the biomarker related risk factors, platelet count more than 3.5 lakh or WBC count more than 11,000 with hemoglobin less than 10, and other biomarkers like D-dimer and tissue factors. These are all the biomarker related risk factors for VTE in cancer. And next, coming to the prophylactic, like treatment, prophylaxis and treatment of cancer related thrombus, how do we manage? So VTE primary prophylaxis, generally whenever a patient comes, we do a high risk, that is corona score if it's more than 2. Then we generally assess the risk for bleeding and any interaction with the drugs. And we consider giving them like prophylaxis for the VTE is rivaroxaban. We give 10 mg daily for 6 months, or we go with apixaban. That is, these are Novaks, which we give apixaban 2.5 mg twice daily for 6 months. So these are the common prophylaxis which we give. And in case of treatment, we need to assess the risk for bleeding, and based on the drug-drug interactions, we either give the Novaks or we give low molecular weight heparin. Whenever there is high risk of bleeding like luminal GA cancers, we go with low molecular weight heparin. Whenever the risk of bleeding is low, even though the patient is having VTE and there are no drug interactions, then we go with novel oral anticoagulants. So these are the common things where we start with the parenteral treatment and then go with the oral treatment for VTE. So whenever it's enoxaparin 1 mg per kg twice daily or unfractionated heparin is given in the initial phase, that is 5 to 21 days. For the oral, we generally go with rivaroxaban 15 mg twice daily for 21 days, followed by 20 mg once daily for 6 months. That is the dose for rivaroxaban. And apixaban 10 mg twice daily for 7 days and followed by 5 mg once daily for 6 months. So in the treatment phase, that is the 3 to 6 months phase, we either give dabigatran 150 mg twice daily, or we can change it to apixaban 5 mg twice daily and rivaroxaban 20 mg daily. This is up till 6 months for the treatment phase. And the extended phase, that is beyond 3 to 6 months, we either go with apixaban or rivaroxaban, that is rivaroxaban 10 mg or 20 mg daily, and apixaban 2.5 mg or 5 mg twice daily. These are the doses of the Novaks which we give for VTE. And next complication which we see is the superior vena cava syndrome. Superior vena cava syndrome, the mechanism by which it occurs is whenever there is any cancer which is infiltrating or obstructing the superior vena cava, when the blood flow through the superior vena cava is compressed, then there is decreased venous return to the heart, decreased cardiac output, and increased venous congestion and edema in the upper part of the body, that is the head and neck. So because of these, the venous drainage of the head, neck, and upper extremities and thorax through the superior vena cava, they are obligated because of compression or obstruction of the vessel with the tumor or the thrombus. Like how we can see in this X-ray, how there is a compression to the superior vena cava, and these are the symptoms which we see generally. So the most common symptoms which we see with superior vena cava syndrome are cough, dyspnea, dysphagia, and head, neck, and upper extremity swelling or discoloration is there, and development of collateral venous circulation and jugular venous distension, and seizures and hypotension. So the diagnosis, chest X-ray, if it's abnormal, then we need to confirm with CT chest. Chest X-ray, we generally see mediastinal widening and pulmonary venous obstruction. This is a case of lung cancer X-ray, which we are seeing here. So then we have to confirm with chest X-ray, chest CT, or else MRI or contrast venography. But most commonly, it's sufficient by doing a chest X-ray and confirmation with a CT chest with contrast. So the treatment is chemotherapy immediately. Suppose if there is any lung cancer or any of the cancers which is causing the SVC, so immediately the disease burden is to be reduced by chemotherapy or a radiation therapy to reduce the tumor. We can place a stent to increase the flow of flow to this head and neck, and diuretics to decrease the edema, steroids which decrease the laryngeal cerebral edema, and thrombolytic agents for clot, and mediastinal radiation sometimes to reduce the size of the tumor. And if any central IV catheter is causing this, then we can remove the central IV catheter. So apart from treating the cause, we can give chemo and radiation. Radiation mainly to reduce the symptoms instantly, we need to give radiation. And the other complications commonly which we see with in oncology patients is extravasation injuries. So these are one of the common oncological complications seen with chemotherapies and some of the targeted therapies as well. So the extravasation, generally when we see any patient taking chemotherapy peripherally, we generally observe for most a few of the patients having extravasation injuries. So these extravasation injuries occur before this extravasation injury. So all the chemotherapy agents we generally distribute into non-vesicants, irritants, and vesicant agents. So, whenever there is any extravasation of chemotherapy, what we do immediately is to stop the IV, identify what is the agent, and take a photograph of the site. If it's a high volume or low volume, which has gone through already, and if it's a high volume, we do a squeeze method, or else we can go with fasciotomy or excisions. Whether necrosis is present or absent, based on that we generally treat. And if it's a low volume, then injury with the internal with the interval of salvage, like if there is no necrosis, an injury outside interval of salvage, then after the salvage interval, then we need to give an immediate conservative management and delay the surgical intervention. If it's a high volume, then generally, if the necrosis is present, we generally give antidotes. We have different antidotes for few of the chemotherapy agents. Dexamethasone is an antidote for anthracyclines, then sodium thiosulfate. And if the necrosis is present, we generally give a saline dilution. For a few of the vesicants, we generally give hyaluronidase, liposuction, and excision is being done. So this is the usual protocol which we follow. Firstly, we stop and disconnect the infusion and leave the needle in place, identify the extravasated agent, and try to aspirate as much as extravasated solution as possible, and removing the cannula. And we need to mark it. And if we have to divide at this place, we have to divide based on our categories, whether it's a vesicant or retent, it's a non-vesicant. If it's a non-vesicant, we generally apply local dry cold compress. Whereas if it's a vesicant or irritant, we generally either go with the if it's a vesicant, we generally go with the localize and neutralize philosophy, or we either go with disperse and dilute. So the agents we generally are these vesicants are anthracyclines and a few of the alkylating agents and antibiotics, whereas dispersing agents are the vinca alkaloids, taxanes, and platinums. So we apply for the localize and neutralize. We generally apply dry cold compresses for 20 minutes, 4 times a day for 1 to 2 days. And for disperse, we generally apply dry warm compresses for 20 minutes, 4 times a day for 1 to 2 days. For the neutralizing, we use specific antidotes. For anthracyclines, we give dexamethasone and topical DMSO. Whereas for mitomycin, we give topical DMSO. Whereas for vinca alkaloids, taxanes, and platinums, we give hyaluronidase as the diluting agent. And we have to keep the limb elevated and administer analgesics whenever the patient is complaining of pain. So these are the this is just brief to explain the extravasation. How do we manage? Because it is one of the most common complication which we see with most of the chemotherapy agents. So respiratory complications in oncology, usually respiratory complications in oncology are like very rare. The type of respiratory cancers which we see are the lung mesotheliomas, thymic carcinoma, and bronchial carcinoid tumors. The common complications, respiratory complications which we see in oncology are dyspnea, respiratory failure, hemoptysis, intractable hiccups, and any pulmonary infections which may occur in cancer. So mechanism mainly of tumor development, as we know, it's because of genetic or hereditary features or environmental influences like smoking, pollution, or there may be interaction between the oncogenes and tumor suppressor genes. And the impact of these respiratory system cancers are obstruction of the airways, which may lead to dyspnea, or reduced lung capacity and chronic cough. And there will be alteration in the gas exchange mechanism and increased susceptibility to respiratory infections. This is the impact which we see with the respiratory function. And these, because of the cellular and molecular changes which occur, like cell signaling pathways, uncontrolled cellular proliferation, and mutations in the DNA repair mechanisms. So the treatment modalities which we see are surgical interventions, lobectomy or pneumonectomy for if it's a directly a lung cancer, which we see. So the patient selection criteria is very important in these, and they follow a step-to-step procedural approach, and recovery process and expected outcomes are also explained prior. And minimally invasive surgical techniques are VATS and robotic surgery, which are being used in thoracic oncology nowadays. And post-surgical complications, which we see, are the infections, bleeding, and respiratory issues. So there are strategies for prevention and management which are being followed by the surgeons. Then coming to the radiation therapy, two types of radiation therapy are generally used in malignancies of the thorax. Either the metastatic to the thoracic malignancies, or it might be a direct lung cancer, which we use our external beam radiation therapy, brachy and stereotactic body radiation therapy. The main side effects are the acute side effects like skin irritation and fatigue, long-term side effects like fibrosis or any secondary cancers occurring. So we will be using the methods to mitigate and manage side effects by doing the contouring, and by following few strategies where we can decrease the side effects to the lung tissue. And this success rate, it depends on the cancer stage and type. And coming to the other therapies like chemotherapy and targeted therapy, which we use in lung cancer, which has got very advanced nowadays. The chemotherapy regimens and drugs which we use, we generally check for decreasing the complications to the patients. And by common side effects which we generally see are nausea, vomitings, neutropenia, hair loss. So we generally need to monitor the supportive care and nutritional lifestyle modifications, and targeted therapies based on the mechanism and the target which is present in for the patient. And some other complications which we see generally in patients with the respiratory complications, which we see in oncology, are hemoptysis, as we have seen. That might be because of any bleeding vessel present in the lung cancer tissue. So in these cases, what we do is we generally give them supportive management. We generally give them anti-bleeding agents, which we give, and then support them with chemotherapies. Chemotherapy causes immediate shrinkage of the disease and the disease burden. Once the disease burden is decreased, it will be very easy for us to manage the further complications of the cancer. And gastrointestinal complications. So gastrointestinal complications are the most common complications which we see post chemotherapies, and they are the least severe which we see. So coming to the severity, gastrointestinal complications are not much severe if we address it at a very early stage, and because they are the most common complications which we see regularly. So common conditions which we see are nausea, vomiting, mucositis, diarrhea, and abdominal infections which occur in neutropenic patients. So for these infections in neutropenic patients are very carefully need to be assessed at an early stage, so that these complications don't worsen and the severity is succumbed in the earlier stages. So common pathways which generally occur, the inflammatory response pathway and specific pathways like VEGF which leads to bleeding, TNF alpha in cachexia patients. So these VEGF agents, as we have already seen, like bevacizumab, the most common complication with that is increased arterial hypertension and also bleeding. So whenever we giving any VEGF agents, we generally give a gap of at least 4 to 6 weeks before going for the surgery. So if any surgery is planned and a VEGF agent is being given to the patient, we have to give a gap of 4 to 6 weeks. So the other common symptoms which we see are hematemesis, melena, hematochezia, and symptoms of anemia such as fatigue and pallor. So the coming to the management, there is surgical interventions like based on the tumor size, grade, presence of metastasis, tumor location, and the obstruction. Whenever there is any GI obstruction present, that is based on the symptoms of the patient. If the patient is having vomitings immediately after having food, or if the patient is having severe abdominal pain, we generally go with the assessment with the radiology. And then based on the obstruction, we can either go with the bypass procedure, like bypassing the carcinoma, and then doing a bypass procedure so that the patient can have his regular food and water, and or else we can go with the feeding jejunostomy. These are the complications by which we treat through using a surgical intervention till the disease burden is reduced. Or even a metastatic patients, we can go with the palliative surgery just to make the patient symptom free. The second option is a systemic therapy. Systemic therapy always depends on the factors like age, comorbidities, nutritional status of the patient, performance status, and mainly the disease burden. the disease burden has a very important role in giving a systemic therapy. So immediately, whenever we feel that the patient will feel better after giving a chemotherapy, the disease burden will be less and the patient will be symptom free, we immediately go with giving a systemic therapy once it is addressed with the surgical intervention. And the radiation therapy role in GA malignancies or GA symptoms occurs only whenever there is any kind of bleeding risk. Like whenever there is any bleeding tumor from the stomach, we generally go with the hemostatic radiation which is given. So this hemostatic RT helps in managing the GA, few of the GA complications. Apart from this, the common GA complications like nausea, vomiting, or diarrhea, which occurs regularly with most of the chemotherapy patients, we generally address it by giving some pre-chemotherapy prophylactic medications. That is, we give some pre-medications to decrease the cancer-induced, chemotherapy-induced nausea, vomiting. That is the CANV. So this chemotherapy-induced nausea, vomiting has multiple grades and based on CTCAE. So based on these gradings, we generally give them the anti-prophylactic agents of antiemetics. So these antiemetics again are of multiple levels. So we give the higher antiemetics for the patients with high risk of emesis based on the CTCAE. And also, we give prophylactic medicines like post completion of chemotherapy for 4 days. They need to take this treatment for vomitings, for diarrhea, and for as an analgesic agents. Also, we just give the patient some prophylactic medication so that they will be symptom free. Yeah. Thank you.
Yeah, thank you, Tejaswini. I think it was extensively covered,
Thank you, sir.
highlighting the fact that many a times oncologic emergencies, which we commonly think of, are very few. But the fact that we had to extend the session into two shows that there are many conditions which many of us don't know or are not aware of it.
Yes.
And thank you very much. I don't think I have much to add to the entire list of complications that you have presented.
Yes, sir. Thank you, sir.
I think Sansham is right. There are certain things which everybody you could not even think that this is possible for a situation, and as intensivists we need to be aware so that we use our judgment and our diagnostic tools more judiciously and more effectively. Thank you very much, Dr. Tejasvi, for an excellent couple of talks. We hope we can link up again in future for more collaborative talks. Thank you all for joining us today. And if there are any queries on this topic, please do post them on the group from where you got this link from, and we will try to answer. Till then, take care and bye.
Thank you so much, sir. Thank you for this opportunity.
Thank
Thank
you,
you.
Tejaswini.
Thank you, sir.